Hello, my name is Dylan Hoffman. I am in the Indiana State DAT program, and this is my clinical philosophy and the framework at which I would tackle any patient. I'll describe this framework from a general stance, but then we'll also have a case to kind of apply in there and get a more practical sense of this as well when it comes to the lower extremity. Uh, so I want to start with the model patient. I actually took this case. This is something I'd done earlier in the DAT uh, uh, using the Nagy disablement model for a patient with iliopsoas tendinosis, describing some of the things, body structure and function, tight psoas, shortened psoas, decreased hip internal rotation, and flexion, anterior tilt of the pelvis, weak 3 out of 5 manual muscle test of the iliopsoas, how this affects the participation, wasn't able to participate in games or had decreased time in practice in games, difficulty with activities like squatting, or pain with prolonged running, jumping activities, and different quad dominant squats as well. Some environmental factors playing into it were the scholarships that the player was getting. He was a senior basketball player, very talented, wanted to continue to play at this high level for further scholarship offers. And the student athlete had a good relationship with coaches, teachers, and family. The mother was involved in the school, and so those are some of the environmental factors playing in as well to this condition and to this patient, and then the personal factors as well, being a 17-year-old male and having have played through this kind of pain for a while. So let's kind of go through my framework. I'll discuss the framework and I'll discuss how the patient fits in. So first step of my framework is the screening. It's important to understand that any patient interaction begins from the moment you meet the patient. And this may be before they ever report an injury to you or they ever even have an injury. From the moment that they're under your care, if you're working in the high school or college, they've become your patient. And so that first step of PPE and screening is important. Working in the high school, the majority of this is the pre-participation physical exam, which gives us a basic understanding of their fitness level and that they're able to do the activities of sport. More specifically, and this isn't something that I've regularly used in my practice, but something I look to implement more, which is the Y balance test as a screening tool to figure out rates of injury or likelihood that a patient may suffer an injury. They're higher injury rates, and the Y balance test is a pretty good one for that. But the idea is that you start to understand the risk associated with your patient in initial screenings before an injury even occurs. This helps you identify some things and maybe prevent those injuries from occurring in the first place. But in a situation like this, where we have a patient and he does get hurt, and we come to this evaluation, there's things we need to do. We need to find the who, what, when, where, and how of that patient. And when I say who, I mean who is this patient? We can look back at the patient model and the disablement model, and we can learn a lot about the environmental factors, the personal factors. Who is this patient? What kind of support do they have at home? What are they motivated by? What is the demands and the activities that they're trying to get back to? So understanding the who is important. The what's going on, the what happened, when did it happen, where does it hurt, where did you get hurt, how did things happen, your MOIs and your mechanisms associated with that as well. During your evaluation, it's important to find the alleviating and aggravating factors. We mentioned that in this, that prolonged running was an aggravating factor. and relative rest was generally alleviating for pain. Then you want to find the severity, irritability, nature, and stage of the pain, the sins of the pain. This is something I learned in my residency program that I've continued to keep a part of my practice, and understanding how severe is the pain. Is it mild, moderate, severe? How irritable, meaning when the pain comes on, does it come on fast and then go away fast? Does it take a while for the pain to start, but then it takes a while for it to dissipate? Are they highly irritable, moderately, or mildly irritable? And then the nature of the pain, is it somatic, nociceptive? Is this peripheral or a sensitization case? And understanding those different natures of pain as well, the tissues involved. Is it a visceral pain, etc. And then the stage of pain. Is this chronic? Is this acute? Where are we at as far as the actual stage of pain they're in? And the idea, if you haven't got it here yet, is we want to understand pain, because if we can understand the pain, that's usually what people are coming in for. As I go through and make my diagnosis, I can use objective test clusters and clinical prediction rules whenever possible. These are being proven in research to help with accurate diagnosis and identification of pain generators and specific limitations. And you may notice that I don't have the specific diagnoses on here. I mean, I do on my model with the iliopsoas tendinitis, or tendinosis. But what's really important is what I'm really wanting to find when I go through my framework is I'm trying to find what is generating their pain. In this case, it'd be the iliopsoas tendon. And then what are the specific limitations? And in our case, we're going to see that they have decreased mobility in their posterior capsule of the hip, that they have muscle weakness, that they have a quad dominant squat, and some of these limitations and things that we can start to work on and evaluate in a manner that sets us up for effective interventions. And that brings us to our next thing, which is treatment. And selecting those interventions that are going to address the specific limitations of the patient. For this patient, manual therapy was a big one. Doing manual therapy to lengthen the iliopsoas, correct any kind of anomalies that we may see, that he had an anterior tilt, correcting some of those things, lengthening the psoas through manual therapy, doing mobility to increase posterior movement in that posterior capsule of the hip, and then coupling that with the functional exercises specific to the patient as well. Not only working on lengthening the psoas, but strengthening it as well, and increasing their functionability, their ability to squat with good form, have good posture, and generally go through functional activities effectively. And to measure these interventions, obviously one of the most important things we can do is outcomes, both clinician-rated outcomes, patient-rated outcomes. But something we can also do is look at an asterisk sign. So a lot of times I may have a patient say they're having difficulty with pain. It hurts for them to lean over. And so I'll have them bend over before I apply my intervention, have them do it after. Couple of benefits. One, I can see, are there any just obvious improvements in their mobility or their squat or whatever I'm having them do. And then I also get to see their reaction to it as well. If they're able to get through it and they say, wow, that felt better, I can ask them a percentage. 25% better, then that gives me some ideas that, hey, my intervention targeted what I wanted it to. And it also gives them some reassurance that I'm selecting things that are going to help them. So measure your interventions with success and outcomes. With this patient, some outcome measures might be really useful, especially to look at the psychological aspects or the psychosocial aspects or even the physical disability. So implementing some patient-rated outcomes as well for that. One that comes to mind is a fairly generic one, but I like to use it, which is the PEDS uh, uh, QL. So looking at the pediatric quality of life inventory assessment is a pretty good one to have a good idea of the disability that the patient perceives. And a couple of tips when it comes to treatment: be flexible, adaptable, and consistent. I think those are really important. And then don't use the shotgun approach. Not only do you need to be able to adjust on the fly, be consistent with your treatment recommendations, but you also don't want to do the shotgun approach where you just throw every intervention that you have. I like to say a hammer works really well with a nail, but it doesn't work well with a screw. And being able to have a lot of tools is great, but don't just throw them all at it. Best case scenario, you don't know what intervention worked and actually helped the patient. Worst case scenario, you don't know what intervention made the patient worse or actually was contraindicated. So be specific in the treatments that you're selecting. So now we move on to our return to activity. This is the 4th out of 5th step in this framework. And we use these outcomes we've collected. We use the evidence that we find in research. We use the patient's input and patient perceptions of their treatment and our own personal experiences. And we use all of this to make evidence-based return to play decisions that we can feel confident about. So with this patient, I could use things, his improved manual muscle testing. We could do a Thomas test, and it's negative for iliopsoas shortness. We can do a functional assessment of his squat. We can do a Y balance test to see has he improved? Is he performing bilaterally within reason to each other, and what are the growths there? Has he improved in his quality of life outcomes? And what's really important here is I have return to activity is a patient's ultimate decision, and I think that's really important. I personally tend to catch myself trying to motivate and push patients back. I'm saying, you're ready, your scores are great, you're doing really well. I think you can get back out there. You should go play. But ultimately, that has to be the patient's decision. And on the flip side of that, we sometimes have to respect a patient's desire to get back in as well. So understand that returning to activity is the patient's ultimate decision. I can provide all of the input and my advice and my knowledge to that and educate the patient as much as I can, but that decision has to be up to them. And then including that is educating the importance of continued care. Treatment does not stop when they go back to their sport or back to their activity. Return to play is not discharge, and that's really important. So many people, most injuries reoccur. Most people have reoccurring injuries. And it's because they think, I feel better, it doesn't hurt anymore, and they just quit. And all the progress that they've made towards injury prevention starts to slip back. So a return to play or a return to activity is not a discharge. So then that moves us to our 5th step, which is discharge. And it's important to note this only happens when that patient leaves your care. If you're working in a college or a high school, that patient is your patient from the moment that they come into the school to the moment that they leave, and they're no longer under your care, right? We don't discharge a patient or in this case, an athlete, even if they're not hurt. They are always in our care. It's our responsibility to provide preventative care for those patients. So that is highly important. Unless they graduate, if you're working in a clinic and they get discharged, or you change jobs and you go somewhere else, that patient's in your care from start to finish. Even when they're out and they're playing and they have no restrictions, you need to be checking in with them. And it doesn't take much to say, how are you feeling? Have you had any problems? Having those short conversations lets them know that you still care about them, you're still thinking about them, and it lets you know that they're doing okay or they're not doing okay. And then through that, we need to encourage and promote healthy habits so that these patients don't relapse, don't re-injure, and they can enjoy the activities and the quality of life that they've worked to get back. So, in conclusion, care starts from the moment you meet a patient to the moment that a patient leaves indefinitely. There's no in between where you have a patient but you're not providing care. It goes from start to end, from the moment you meet that patient to the moment that that patient leaves you, and there's a good chance you won't see them again. So understand that treat the patient, not the pathology. I mentioned this. Diagnosing things correctly is important, but it's more important to understand who the patient is, what they want, and what limitations they're having. What's causing their pain? Why are they coming in to see me? Because they're more than likely coming in because they want to get healthier, they want to feel better, they want to have better function, and they want to have less pain. So let's treat those things and let's help them in those ways, and not focus so much on being the detective and picking the right pathology. Let's pick treatments and interventions that treat the patient and what they need versus just trying to diagnose. Because I can diagnose correctly or incorrectly all day long, but unless I'm choosing and I'm evaluating to treat, not to diagnose, I'm not going to be the practitioner I want to be. And then once I've come up with this selection, it's the quality of the interventions and what you choose versus the quantity. So don't just throw every technique you know at the patient. Be selective, be decisive, and know why you are selecting the intervention you're selecting, so that you can provide better care. So it's not the it's the quality of the intervention, not the quantity of interventions. And I think that's an important conclusion. And then lastly, remember to educate and encourage compliance past return to activity. We did this with this model. Once we started getting this patient back without restrictions, we encouraged some self-care techniques that this patient could use at home before and after practices to help minimize the chance of a relapse. And this patient did not have, we had mentioned that this patient had on and off hip pain for over a year, and we were able to get rid of it in a relatively short amount of time, and we were able to keep it away until discharge, until I left the position, which would have been about 6 months later. So important aspects when we're using this framework for patients. So thank you for listening in. I hope this was informative, and that is my clinical philosophy in a nutshell.